Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I have two very special guests. I have Stacy Shackelford, and I have Doc Rush. Hey, Doc Rush, how you doing?
Hey, Dennis. Good. Thanks for having us.
Hey, Stacy, how you doing?
Hey, Dennis. Awesome.
Perfect. So, obviously, everybody knows Stacy. She was just on the last podcast. But Doc Rush, if you wouldn't mind doing a real quick intro.
Sure. I'm a citizen soldier, citizen airman. I'm a National Guardsman. And my original career was as a radiation oncologist, specializing in the treatment of head and neck cancer and brain tumors. I also had a brief period where I was a general surgical intern in the 80s, and then an ER doc for 2 years before I went into radiation oncology. And then in about 2008, at the age of 48, I swore in and joined the military to be the team doc for the 103rd Rescue Squadron, a PJA Guard team in New York. And through a the usual weird set of circumstances, I became the Air Force Pararescue Medical Director from 2012 to 2018, remain active on the TCCC committee and in support of Jamie and the PFC team and everything else I can do to help support the mission.
Very good. So, obviously, I think both of you are probably perfect guests for this this particular podcast, and it's on triage. So, as we're kind of morphing from the Afghan-Iraq conflict into a giant question mark of what the future conflict is, the concept of triage keeps coming up over and over again in various different aspects, and how important this will be, and for at least what we think about is the future fight. So I guess my first question is, what are we doing wrong?
Sure. And for the listeners, I want to emphasize that my bias is going to be towards the pre-hospital space, and I am not going to speak I'm going to speak at the medic level, not at the sort of role 2 doc level for now. So what are we doing wrong? The medics aren't doing anything wrong. As you guys will see in a series of publications that'll be coming out, we're going to try and change the way we think about how we do triage. So the systems of DIME, ID Me, START, MASS, SALT, Jumpstart, all these algorithms and acronyms that have been created. It reminds me, and Colonel Shackelford will appreciate this, when I was a general surgical intern, my grandmother had a hiatal hernia, and we came in and the surgeon said, well, I'm going to pick this one of the 8 hiatal hernia surgeries. I'm like, what the heck? And he's like, yeah, if we had one really good operation, we would have only one operation, but we don't have one really good one. So we have all these systems that have not been standardized. There's no universal approach to how we should do triage. So right away, that speaks to one of the issues with triage. The other thing, the way I got into all this is while I was the PJ Med director, I debriefed as many missions as I could. And it was clear to me in the AARs that at least in the tactical setting, we were always prioritizing safety and security. So if it wasn't a secure area, there was nothing fancy going on as it related to triage. And then a lot of the triage was really clinically based and intuitive, always based on pulse, respirations, and mental status, but nobody really using these complicated menus with arrows, if breathing, yes or no, and then go on to the next thing. Nobody used those things. The other thing we found in our combat series, which I presented at SOMA and will be submitted for publication, is that in 30 operations ranging from, like 4 to 6 casualties, multiple casualties, to Khobar Towers with 520 casualties, there were only 2 instances where people marked the patients. And those were nighttime missions just with IR tags. They weren't marked for colors. People were essentially geographically triaged. So you put, the real serious patients together and they'd be exfilled first, unless there were different loading patterns of the ground vehicle or the rotary wing vehicle for evac. So that's the second thing, is that no colored tags were used. And then the final thing is all of the systems have 4 to 5 categories. In reality, people use 3 categories, and that was essentially now, later, or dead. And, we could say expectant or deceased. But in most instances, especially where teammates were involved, there was no such thing as expectant. People tried to save everybody, but you would use clinical judgment and maybe transport somebody who was more expectant than going to make it. You transport them a little later and use some clinical judgment there, or tactical judgment. But essentially, 3 categories were always used: who needs to be exfilled now, who could be exfilled later, and then who was actually dead. And in the exfil later category, I think this whole idea of having a green category, or a real ambulatory category, minor concussion, cuts and scrapes, sprained ankle, or whatever, people who could return to the fight are always being returned to the fight. On the civilian side, the people who could self-triage and go to the hospital on their own are going on their own. And really, to break it up and complicate it by saying, well, we have a litter stable group of people, which is how I used to do it, and an ambulatory stable group of people. We just need to call them a stable group of people. And then the team leaders are going to determine the load patterns in terms of how many stretchers and ambulatory we're getting into each bird or each vehicle. And as we can talk about a little later in the details of the things that I've thought about, is that really just get everybody out of there as soon as you can. And some of it's just, loading patterns, and it might be tactical and not medical considerations. So we could get into that a little more. So the things I want to leave you with in response to what are we doing wrong, it's the way we're training people, I think, that we're doing wrong. And it was nobody's fault. Everybody had the best of intentions by creating a sophisticated algorithm-based kind of category system. So that would be my opening to that question, Dennis.
Perfect. So Stacy, kind of same question. So the last podcast, surgery for non-surgeons, you mentioned that very frequently downrange you were receiving patients that didn't actually need surgery. So again, what are we doing wrong?
I think we are thinking on a small scale. We are thinking in terms of assessing individual patients and categorizing them. This approach goes back to back to Napoleon's era and his chief surgeon Leray, but we're not actually scaling our approach to to really large mass cal events, and we're not developing a different approach for events that are truly overwhelming. I think our experience has made us very good at responding to mass cal events in the range of 20 casualties, maybe up to 50 casualties. But when you start getting into hundreds or thousands of casualties, this approach of assessing individual patients, categorizing them as specifically into 1 of 4 categories, making this sort of I am God decision, you are expectant, this is not going to work. And I think what we've really tried to do is frame this in terms of treating the population, sort of quantifying the scale of what we're talking about here, adjust our goals accordingly. When I have 20 casualties, my goal is to find the sickest ones and treat them first, so that they have the best chance of surviving, and identifying everyone that can wait. But my goals are going to change if my resources are just truly overwhelmed. So I think we don't really have experience with these large of events. So what we've tried to do is look at the data we have from CENTCOM in terms of what injuries are killing people, what is the time to intervention that is that can save lives, and on the flip side of that, what is too long, and people will die because they're not getting interventions quick enough. So really, to apply a data-driven approach And again, it is, when we start talking about these really large scale events, it is somewhat theoretical, but I think we've really tried to simplify it and use some driving principles, which we can talk about.
Yeah, absolutely. I mean, man, and even I think what you were talking about, Doc Rush, when we were at Soma, a lot of this is on the purely medical side, the confusion, I guess, of the different color tags and things like that. Then none of that ever made sense to begin with. But
it's so ingrained, though. It's amazing how like every type of training event you go to, every course, like those 4 categories are really ingrained.
yeah, that's one of those things, like it's kind of ingrained, but nobody actually knows what the frick they're doing. Like they know the extremes of things, but once you get to the middle ground, it's kind of a crapshoot who ends up in what. But how do we kind of meld this? Because you have the military aspect as well, right? We have an operation going on. We have work that needs to be done, and now we have a casualty, or we have 100 casualties. So I mean, I would think triage kind of has to kind of be somewhat inclusive of this military aspect as well. Kind of the life or limb type of kind of issue. Like he's not going to die, but I don't have the time nor the capability to hold on to this person. There's got to be some kind of aspect to that, I would imagine.
I feel like what we've tried to do is really just take out the individual decision making, like assess individual patients and making a decision on individuals. We've tried to take that out of it to a good extent. And, what we're really looking at is what we call first pass actions before you make your formal triage decision. And it really depends on the time, from the time of injury to the time that you're seeing the patient. So we know that first 30 minutes is really, really critical. That's the most important time where you need to stop external bleeding, clear the airway. The first hour is really essential in terms of, moving the patient, getting them to surgical location. But if you can't respond within that first hour, there could be a million reasons why you can't. Maybe it's mission related. Maybe it's, whatever the threat is ongoing. Maybe it's just a really large scale event and you can't get the medics to the patients within the first hour. And so in that case, your response is really different. All the people that are bleeding to death have already died. Now your population is really, truly different. So really the first pass actions are what the biggest life threats are. And we've known this for a while, but bleeding to death, that's number one. So number one, stop external bleeding. And number two, clear the airway, make sure the patient can breathe. It doesn't have to be an advanced airway intervention, but if there's something, if they need to be extricated from a suffocating situation or pulled out from under something, etc., those are the two actions that you really need to take immediately, as soon as you can.
Let me expand on that a little. It's sort of the direction we're going in. For the medics, I want you to think of 4 phases, so to speak. As Colonel Shackelford referred to, the first is going to be the usual TC3 stuff: stop the bleeding, make them breathe. And a lot of that is going to depend on the realities of the situation. If you are a medic embedded at an event that happens and you are magically spared, you will be able to put on tourniquets, pack wounds, and open airways. If you are a medic in a QRF or some other responding force that is getting there 30 to 90 minutes later or hours later for a plane that's shot down and there are survivors or whatever, one of the things we've learned from the Alaska PJs who've been responding to plane crashes for about four decades is that they don't even worry about the first pass TC3 stuff. They're getting there 1 to 4 hours later, typically, And people who are going to die who needed a tourniquet or surgery will have died, or they'll be in irreversible shock. And they're really just worrying about, survival needs. So the way I want to break it down for the medics is I want them to think of 4 phases. The first phase, and we could come up with better nomenclature. We're just sort of making this stuff up now and trying to codify it. But the first phase is going to be TC3 MAR, so stopping the bleeding and opening the airway. The second phase will be the 30 to 60-minute phase of getting patients blood transfusions or surgery. So as Colonel Shackelford has elegantly showed in the time and triage paper that's being published, that if you don't have a blood transfusion and you need it, you don't have it by 30 minutes, it's not going to help you. And if you need surgery to stop the bleeding, it's unlikely to help you after 60 minutes. So that second phase is going to be blood transfusion and surgery. The third phase, I'm going to deem the secondary survey phase. Cleaning wounds, getting antibiotics on board, pain meds if you haven't already done that, and some splinting, fracture stabilization, that sort of thing. But we've gotten past the lacerated iliac arteries and the pelvic fractures and the hemothoraxes that are going to bleed to death. And we can include chest tubes and things like that in that. But then the fourth phase is really comes out of my discussions with the FDNY. What do we do on Manhattan Island where we only have like 6 or 8 points of egress and rotary wing is a waste of time when we have thousands to tens of thousands to hundreds of thousands casualties potentially from a nuclear explosion or something crazy like that. And then we're talking about survival needs, shelter from the elements, warmies, water, and food. Plus, I'm going to just say quite simply, pill packs and stuff to clean wounds are going to be the last thing. And I get that also from Khobar Towers, and we could talk more about the difference between the Beirut bombings in the 80s and the Khobar Towers in the 90s and what we learned from that as far as what we need to do. So, but if we just sort of categorize those things into immediate action, you're a medic on scene and you happen to have survived, and you're there to help stop the bleeding, make them breathe. Then you're a responder, or you're gonna find those, what's it going to be, 5, 10, 20 patients you can actually operate on and get blood into. And then later on, it's going to be the secondary survey stuff, what we call pause, pain, antibiotics, wounds, and splinting, and then finally survival needs. So I think if you start thinking about it, and then this gets into what Colonel Shackelford's referring to in terms of scale, if it's going to be a base, with tens of thousands of people that really takes a hit with thousands, forget about going from dozens of casualties to 100 or a couple of hundred, God forbid we could be going to thousands, and how you're going to think about it. And that's how I look at the Khobar Towers response over, 24 to 48 hours. So just to break it down, that's the big thing I want the medics to walk away from this discussion as they start to think of SOPs and how they're going to plan for it. And of course, the plan's going to change based on how fast can you get evac in, and are you going from the middle of Asia to one of our Role 4 hospitals, so those are a couple of big picture things that go along with Colonel Shackelford's idea of let's change the way we think about it to thinking about scale, which is very different than some of your original questions about what do we do with the 1 or 2 or 3 people in terms of triaging them when it's a PFC thing and we have, 5 days of ground evacuation in some other nation, where people are really isolated. And I think that becomes a different discussion as it relates to uptraining medics to a more shock trauma role and less of a secondary, shooter role and things like that. So it's a very wide-ranging discussion.
Your point about time is important, I will say, because it really depends on the time that the first responder arrives. And so, for instance, that first phase of MAR really only applies during the first hour. Really less than the first hour, realistically. Really the first 15 minutes. And so you're right. Like, if you arrive an hour after the incident, when the injuries occurred, that phase 1 has already passed, and now you're really moving into the second phase, which is dealing with their wounds, etc. And then, yeah, just to talk about the scale of event, we thought about, in terms of standardizing a terminology, 3 different size events being multiple casualties, mass cal, and ultra mass cal. And we all know that the size of the event really is proportional to your resources, and that determines your response. But just to have a way to think about it formally, if you have multiple casualties, and the reason this is important is because your goals really change depending on the size of the event. If you have multiple casualties, we talked about before, your goal is really to save everybody who has potentially survivable injuries as much as possible. And so in your triage process, you're really trying to identify those that are, those that require surgery or advanced life support interventions first, and get those people treated while the other people can wait. And then not to waste resources on the expectant patients, but really not to let any patients with potentially survivable injuries die. When you go to a larger scale event, which we're calling mass cal, now, just by the nature of the event, it's likely that it will take longer to get to the patients, and your resources will be much more limited. And so in that case, you really may need to conserve resources, which literally in the last 20 years in CENTCOM, we've really never been faced with this situation, hardly ever, that we had to allow patients with potentially survivable injuries to die due to lack of resources, just because we had so many resources. And we found that the 2 most high resource intensive interventions are blood transfusion and ventilator. And so for those patients who literally cannot live 1 hour without blood transfusion and ventilator support, those are your most resource intensive patients. And if you're really short on resources, the thing you can do is not necessarily go around and declare people expectant, but just not be aggressive about getting blood and ventilator support to those patients within the first hour. Unless you've done everything else, unless all those patients have, had their airways cleared, external bleeding control, et cetera. But it's not the priority in the first hour because it's so resource intensive. And then we get onto the ultra mass cal. This is what Steve was talking about, where the response is truly delayed. The only intervention that is likely to meet the timeline of life-saving interventions is TC3 from those people that are already on the scene. And I think that's important to emphasize, because when we talk about, it's a large, huge event, people are just going to die, can't do anything about it. I think the message should actually be, we can do a lot, but it's all at the TC3 level, and that will save the most lives. When getting people not only trained, but equipped with tourniquets, et cetera, will be the way to save lives in an ultra mass cal event. The medical interventions are going to be truly delayed. And, those people that can't live without a blood transfusion or ventilator are unlikely to survive at that point.
So, all of that makes sense especially on an academic level, just us sitting around talking about it. How do I go about picking and choosing? So I'll let Doc Rush have a chance because it looks like he wants to talk. But how do I face, let's just even say like 24 people, because if you're talking about thousands, like just give the drugs to yourself because you're gonna need them. But even just a couple dozen. Like how do you sift through all these people?
Yeah, so I think there are a couple of things, and a lot of them go into preparation and rehearsal. The first thing is to psychologically prepare a 21-year-old new 18 Delta PJ Corpsman that this is essentially an impossible situation that nobody gets correct all the time. And the bottom line is, let's just exaggerate it, one medic for 24 patients, 24 patients. Everybody knows that when that one patient comes in a trauma bay or you have that one casualty, that takes up your whole bandwidth, right? So one thing that we've done in our exercises for the past 6 or 7 years is I'll give a medic 5 to 8 patients just as a practice thing, and we'll line them up and literally, and let's just say that you have battle buddies who are able to bring the patients to a medic centrally. And again, these are concepts. Everything that Colonel Shackelford and I are talking about are concepts to give you principles from which to deviate in individual situations so that at least the medic has something in his or her mind. So what we do is we'll line up 5 to 10 patients or whatever the number is, and they'll go down each one and do M on each patient, then A, then R, then start lines, or give them pill packs, whatever we determine, is feasible. So that's one way to do it, is like Colonel Shackelford used the term first pass actions. Just walk around, and if you see extremity hemorrhage that you could manage with a tourniquet, do it. Then if you see junctional wounds that you can manage with some wound packing, do it. You're not going to hold the 3 minutes of pressure, but that's where you might use crew resource management, other people to help you. And you do each thing sequentially. And, with the bleeding and the airway thing, we'll always remind people, hey, 1 to 2% of these people are airway problems. The overwhelming number are bleeding problems, period, end of discussion. And we're not even worried about decompressing a chest until later on because of the 30 to 60 minutes it takes to create a tension pathophysiology or so. So that's one thing we do, is we have a very specific exercise in a mass cal where we line up 5 to 10 patients with different injuries, and we let them go. So like when they get to the TBI patient who's unresponsive, but they're not bleeding, they walk past them. If they don't want to sit and deal with an NPA for trismus or a crike, if they have other things to do. And you really have to mentally prepare young medics to just do their best. They're not going to be doing anything wrong because nobody knows how to do this absolutely correctly. And that's what I tried to show with the civilian literature review, which will be published in JSOM, that we presented, which is, number one, none of these systems are more than 50% accurate. That's number one. And number two, getting back to what you guys were talking about, which is the neuroses and psychoses with the colors and the categories, is that in training in civilian medics, about 3/4 of people will try to use those systems. But in the real world, less than 20%, less than a fifth or so, actually use them. So we want people to have the freedom to maneuver and not feel hemmed into these things. My bias is we need to stop teaching them. But the way to prepare people is to have these discussions, but then to do drills. And one of the ways to break it down is do M first, then A, then R, and do it in order, right? So the medic has a way that he or she thinks and can go back to it. And I've seen experienced trauma surgeons say, hey, I'll step back when things are going bad and just start with them again, and go through it methodically.
And I mean, another way to emphasize what Steve is saying is that you really need to offload the decision making in the first response. And if you're arriving at a scene within the first hour, you really just do two things. Stop external bleeding and, make sure they can breathe. And by clearing the airway, it may just be putting them on their side or getting them out of a burning, contained space, etc. Make sure they're not being crushed by something if you can, if you're not wasting time, and do that as quickly as possible. And that way, you're really not making any decisions. Once you've done that with all the casualties, now you can take a moment, take a deep breath, and then try to figure out, okay, do I have evacuation resources here? Can I get these patients with, penetrating torso hemorrhage to a surgeon? Can I not? Maybe at that point I can do my formal triage. Where you're doing, and by formal triage, we put out unstable, stable, ambulatory as an option. We call it USA triage. But I don't care if you use dime or starch or whatever you do at that point. Once you've done the first pass actions, then you do need to circle back, reassess all those patients, begin moving them, extricating them, whatever at that point.
Yeah. I mean, I think the way Doc Rush kind of framed it before, the dead, the not dying, the potentially dying, is probably, I think that's more reality than anything else. But what I guess I have a hard time kind of framing in my mind is, out of all this chaos, we're just running around putting tourniquets on people, putting them on their side, and kind of letting time kind of triage things. How do I say this one person out of this giant pile of people needs to go to Stacy, and it's worth sending in a helicopter in amongst, this enormous threat of, whatever it is. How do I determine that? Because I think ultimately this is why we're going through all these ridiculous training events on, I'm going to teach 18 deltas how to be a surgeon. We just need to figure out who actually needs the surgery to begin with.
Okay, that's a great question. And this is really where, one of my goals as the PJ Med director was to put people's mind at ease. So there's a big difference between talking to a civilian paramedic who does that 40 hours a week and talking to an operator who has combat, tactical, intel, other duties, or PJ's rescue besides the medical piece. You're not a full-time medical provider. So to answer your question, number one, you almost shouldn't be looking for that one person. You should be managing the problem. And let's just step back for a minute, where Stacy and I have been focusing on stop the bleeding, make them breathe, get ready to leave, organize them, CCP, figure out the categories. There's a piece before that we want to always emphasize to the medics, is the tactical piece. So time and tactics almost always take precedence over medicine if the team leader says that's the case. So that if you're in a situation where you respond to a plane crash and there's jet fuel and there's a fire going on, you're actually going to move the people out of danger before you do medicine. If there is a remaining enemy threat, whether it's secondary devices, further indirect fire, or sniper or whatever it is, you're not doing medicine. You're addressing the threat. You're moving casualties to a CCP that's in a relatively safe location where you can move. So I still like to liken these things to the phases of TCCC. Is this a care under fire situation? Is there enemy threat? Is there literally fire and smoke? Is there other noxious fumes? Is it Syria with nerve gas? Is it something where we cannot stay put, stay in play? We need to prioritize casualty movement over casualty treatment. These are decisions that you guys are going to make intuitively if you have the right training. The other thing I like to say about the special operations community is you guys have already been selected, right? Which is very different than an 18-year-old 68 whiskey who's a conventional guy without the same training and without the same selection. So you guys often intuitively know how to figure that out. Do I move the people first or do I treat them first? If that's something that we have to really be teaching you at some point, I think we've done a bad job. And when I say the royal we, the people who've done assessment and selection, us training you guys as medics. So that's the first thing. The tactics always have to be considered, and we don't want that to get lost. While Stacy and I are physicians and we focus on the medicine, I don't want that to be lost in this discussion. I want it to be emphasized to the operational medics that time and tactics often or almost always take priority over actually putting on a tourniquet or, doing a crike on somebody. That's number one. Number two, and this is people who have listened to me before have heard me kvetch, that's a Jewish word, complain about this stuff forever. If we want to put on you guys to be really good at triage, we need to be mandating 6 to 12 weeks of hospital rotations a year. If you're not doing the primary surveys in a trauma bay of all the patients and then seeing what they look like and what their CAT scans and their ultrasounds and all that show and what you find in surgery, and you guys putting together the physical findings, the general appearance to what's actually going on inside the torso when the surgeons get in there, it's fantasy that you guys are going to be expert triagers looking for that one person out of 10 to 24 or 2 or 3 and prioritizing them. So let's just be clear about this. If we're just going to prioritize for the medics being on the range and not being doing clinical rotations and being awesome at physical diagnosis, I think we're kidding ourselves. So that's why I want to take the pressure off. And like Stacy says, take the cognitive bandwidth off these people. If you don't have the experience of being in the hospital 1 or 2 months a year and seeing what these patients look like and who really looks bad and who doesn't, that's also what we showed with our literature review, that these systems are completely inaccurate at picking out who needs a critical intervention or who's going to die or who would benefit from surgery. So to me, I'm just going to keep putting pressure on our community that if you're not putting people in the hospital every year or the trauma bay doing these rotations, the rest of it, I think, is like fantasy. We cannot teach you to do it. And that's why we have surgeons do 5-year residencies so that they get pattern recognition and they see all the odd things and they know what they look like. And then they intuitively respond. When I listen to Stacy and Joe DeBose and Warren Dorlack and David King, all these people talk about what they do, it's all automatic response because it's pattern recognition and they know what to do. They've done it 100 times. So let's put that, back in the equation as far as being realistic.
Important it is because we're literally putting other people's lives at risk to take this person away. How do we train that?
I mean, what I think is important to it's not necessarily important for them to decide who needs surgery. That's why I like the unstable, stable, ambulatory categories. And I like leaving out dead because I don't think that we need people to make that decision that people are expectant or or they have unsurvivable injuries. I don't think that decision needs to be made. So I think really what they need to decide is if they're unstable. That means their vital signs are abnormal, their radial pulse is weak, they lack a radial pulse, their breathing is in distress, or they have an altered mental status. Those are basically, the unstable patients. If you want to throw in penetrating torso injury into that category, I wouldn't argue with you. And then stable patient, this would be one that can't walk out of there, but is, has a serious injury, maybe has a tourniquet on, etc. But is alert and has normal vital signs, palpable radial pulse. And so really, I think that's honestly the only decision that you need to make. And then, if you're starting to really drill down and between the unstables, which one is more unstable or less unstable, I don't think you need to make that call. Just get the first one that you can with altered vital signs, altered mental status to the movement platform as soon as you can. And that's assuming that you're, targeting that golden hour. This is all irrelevant if your response time is delayed.
Dennis, I have another perspective from the operational side, and that is, I think it's the medic's job, and we're going to call, Army medic PJ Corman, we'll just call them medics for now. It's the medic's job to do what Colonel S said, which is stable or unstable. It's the team leader's job to determine risk management. So if you have a young medic, if that person is acting like a controller and calling in air support, including evac, something has gone horribly wrong. So my perspective in pararescue has been, and you correct me from the 18 Delta perspective, that the PJ medic's job is to say, this person's dying and needs a roll 3 or, whatever it's going to be, or movement to a roll 2 with DCS or whatever the capability is. And it's the team leader's decision to take that risk management as Do we take the risk or do we not take the risk? And we all know, I could speak on behalf of Pedro, that once you tell those helicopters with the miniguns and the PJs in the back that we have somebody who's dying, and that was always the difference between Mert and Dustoff, is, they would say that Mert would fly around, and if they heard gunfire, they would turn around and go home. Dustoff wouldn't even take off if they didn't have Apaches. But Pedro, I'll just speak on behalf of the Air Force. They will, if you ask them, and if there's not somebody like holding those guys down, they will launch for you. So once the team leader decides we want this guy out, a tactical evac will come in. So I think that's a team leader responsibility, not the medic responsibility. Do you guys, and I need you to educate me here, is the 18 Delta often making that decision on evac risk, or do you guys have a team leader who's making that decision, or an officer?
It's the team sergeant, because this guy has had a decade of experience doing this job, right? So, from a Delta aspect, I'm pushing up, this guy needs to get out, but the team sergeant is the one who's looking at everything like, this is not a good tactical advantage to bring this helicopter in. We need to move, or we need to do whatever it is.
And I mean, every situation is different, and again, I would tell that team sergeant, if it's been over an hour and the guy has already survived an hour, then, the urgency of getting him out of there is vastly less than it is if you've responded and, the guy's bleeding to death, and you still have a chance of saving him if he gets to a surgeon within an hour. So that timeline is so incredibly important, and it should inform your decision making.
But unfortunately, he's depending on the medic to tell him the information, because I will tell you, from a medical aspect, the 18 Delta is essentially God telling the team sergeant that his Echo or whatever will die if he doesn't get him out. And so he has to weigh that compared to the lives of the people on the evac platform to get this person out. And that's just current conflict, not to mention going forward, where you are constantly, just looking at the last podcast from the air doc from the Ukraine, is like you are running from artillery fire constantly. So I can't even imagine that aspect right now.
Yeah, I just think there's a lot to be said for the psychological preparation of new medics, that you're going to be in difficult circumstances where you're going to lose people. You're not going to be able to save everybody. And I think that there is a benefit to preparing their minds by telling them that maybe, right, nobody gets enough training, but if you could do FMPs, full mission profiles, where you throw that in, like somebody says, in the Guard, I don't even have enough access to my guys, and we don't do enough training where we have people die on them just so we could get used to them. You lost this guy, right? So we can desensitize them to post-traumatic stress from being a medical provider, that you didn't save somebody's life or your buddy's life. And I don't think we do enough of, like I complained to the pararescue career field. We do a lot of rescue training, but we don't do a lot of recovery training. The FEMA teams put cadavers in piles where they have the dogs find them, but we don't have enough people bagging cadavers into body bags and carrying them and feeling, sort of how gruesome all that is. It really, it's disgusting, essentially. And it's very traumatic to some young people, even if they're cool operators. So I think everything that we can do to, tabletop these things, even if you get something in their head, even if it's just a discussion, hey, you're going to be overwhelmed. Take a deep breath. ABCs, always be calm. You're going to get, slow is smooth, smooth is fast. Keep going through those mantras, but letting them know that they're not failing. They're in a situation where people are going to die. That's just how it goes. Like, not every patient, even if the trauma surgeon stops the bleeding, a lot of those people are going to die of sepsis later, or something like that. So it's important for our health and well-being as medical providers to be prepared for that. And I think that's something that we could do a better job of across all of SOF, which is prepare for failure. And we don't do that enough.
Right, because soft always wins. Like I said a while ago, Stacy, you had mentioned that there was a lot of guys coming in on evac that didn't actually need surgery, even though they were declared that they were urgent surgical at the time. I guess how do I determine that this person actually needs surgery? So they've survived the first hour. I've done hemorrhage control. I've done airway. And we're just sifting through this giant pile of stuff. Who actually needs surgery?
Well, the first thing I would say is I don't really see that as a problem. So if they get designated as unstable because they have abnormal vital signs, they need some type of advanced resuscitation, whether or not it's surgery or whether it's just a chest tube, an advanced airway, blood transfusion, everything in ATLS versus an actual surgical intervention. I don't think it necessarily matters. We are looking at, can we put advanced resuscitation teams on the battlefield to help try to stabilize patients or prolong the golden hour, that type of thing. But for the most part, especially when we're talking large scale events, I don't really see that as a problem if they're designated as, again, I don't really like the urgent surgical. What are the 4 categories? I don't even remember what they are, but I don't even like those. I mean, these categories are not really all that useful to reality. So I would rather, instead of urgent surgical, I would just as soon call it unstable and get that patient out of there, get them resuscitated, get them to a surgeon that can do an x-ray, do an ultrasound, do a CAT scan, maybe depending on where they are, and figure out what's wrong with that patient and then give them the treatment that they need. So I don't actually see that as a problem. I mean, maybe in the future, could we try to be more granular and really be able to diagnose torso hemorrhage and chest hemorrhage, pelvic fractures on the battlefield? I mean, some things are kind of easy. You can see them, like high amputations or mangled extremities above the knee. Every single mangled extremity amounts to at least 9 units of blood transfusion, so you're near massive transfusion right there. So some of those just really bad extremity wounds, they're easy to see for one, and they certainly require a lot of interventions. But I still think it just gets back to offloading the decision making. Do the interventions, the simplest interventions that you can. Don't expect to do more when you're truly overwhelmed. And then, once you've done the, external hemorrhage control and airway clearing, then you can take more time to reassess the patients and determine if there's more that you can do in that situation, or how long is it going to be till you move the patients. You can have more time to make those type of decisions, and there's not a single answer for every scenario.
That's the A&S piece. That's why you guys are specifically selected to be able to operate in ambiguity and uncertainty. That's why it keeps coming back to me. I love SOF. I love conventional forces, but everybody has a different role. So at least within, the PFC podcast for the SOF community, part of that you're actually selected for. That's what I keep coming back to. We cannot train for every imaginable circumstance. I think the beauty again, to sound like the self-licking ice cream cone of, how much we love you guys. The beauty of ANS is that you have been chosen, that we can't come up with every scenario and every permutation and every contingency. What we can do is give you basic principles: stop the bleeding, open the airway, move patients out of danger, eliminate the threat first. And then you guys have the DNA plus hopefully enough basic training, mastery of the basics, that you can manage it. So I've gotten away from what you're asking, which is, can we prep for every contingency? That's the beauty of the tier one guys, right? That they have unlimited budget, they have no staff responsibilities, and they train the Bin Laden mission and come up with a week of rehearsals that have 87 different contingencies. When we did the Thai cave rescue, the beauty of what Derek Anderson and Charlie Hodges did was they literally sat down and started at the mouth of the cave and said, okay, walking in, what are the problems? Entanglement with electrical lines. The water is too murky, we can't see it. The child, we're swimming the kid out. The seal breaks. How are we going to, what are contingency plans for if the seal breaks? And one of those was use oxygen, maximum oxygen in the tanks instead of air. So we supersaturate their brains so that if they're underwater 8 minutes instead of 4, maybe we'll buy a little more margin. So, having those principles of mission planning, operations, and having that mindset or the DNA of being able to troubleshoot on the go, I think all those things together is what makes you guys unique and will continue to make you successful. So I have given up on trying to figure out what are all the things that could go wrong in a combat situation, because I don't have experience. That's the team sergeant's job, right? In the end, how am I going to handle all that?
But that being said, we are asking for a little bit of a paradigm shift here. And so we do want to, I think the way to get after this is really actually with some tabletop exercises. So to summarize sort of really the paradigm changes, classifying the scale of MASCAL, the timeline of life-saving interventions, first pass actions prior to formal triage, simplifying the actual triage decisions, and then that sort of concept of ultra MASCAL is really primarily casualty movement and survival needs. And so those are really the new concepts that we're really trying to emphasize. And I do think the way to get after it is just to teach this through a series of tabletop exercises, get it out there, get these concepts into the curriculum. And like Steve said, once you've kind of thought through these concepts, really, it's really
I think you're
actually
right.
a simple thing to do, because it offloads a lot of your
I don't even
decision
know what to
making.
say. It's one of those.
It's overwhelming.
It
There's
is
no
completely
question.
overwhelming.
And it's horrifying. We're talking about like Ultra Mezcal. We're talking about Hiroshima and Nagasaki, essentially. A disaster.
Right.
But within the realm of what you could control, we want to give the medics these tools to manage 2, 3, 4 dozen casualties by themselves.
Right. Because the way we're training right now, it seems like it's such finite detail, when actually we should be looking, right. Mm-hmm. Yeah. Man, oh man.
Looking at the population,
you're just nailing
like
guys on
instead of focusing so much in
the
on each
minutia,
individual patient.
After talking
with all
to you
that
guys,
amount of detail.
We need to be broadening this out to dozens. I can't. That's even a small population. You know what I mean? Especially if they're talking about these ultra MASCALs where you're looking at thousands of people. I can't even imagine you putting eyes on that many patients.
No, you don't.
You're
Yeah,
not.
the people on
That's the whole
scene
point.
are literally the only people that are going to help the patients within the first hour.
Right. And essentially you're using time to kind of triage, because that's, I mean, talking about, let's just say 100 patients. It's going to be an hour before you circle back around to get to the first guy that you just saw. You put, a tourniquet on and you rolled him on his side.
And that's if they're actually next to each other. So we do a lot of plane crash training with debris fields, and I always stick a couple of people in the bushes because they got to search and have accountability, right? So accountability is another tactical piece that we haven't even gotten into in this discussion. But I think what that we want to leave you guys with are these overarching principles that Colonel Shackelford just mentioned, and I think those should be the 4 or 5 pillars of how we go forward and teach and then run exercise.
I just want to get my head wrapped around, this concept of triage in such a dynamic and incredibly difficult environment. And really, like always, it comes down to, basics: hemorrhage control, airway management, if necessary, dealing with the chest. But, essentially time is the big triage decision maker. And then it's kind of like a nicety on top of things. If you're able to get somebody out, choose wisely who gets to go to the surgeon, because it's going to be like a very few.
Yeah, and I think it's really important, again, when we train young operators, that these are not perfect decisions. And again, if you're not putting people in hospitals,
Mm-hmm.
they are not intuitively going to know stable and unstable. But if they still rely on pulse, breathing, and mental status, they won't go wrong. And I think you just reinforce that it's impossible to make, that people are going to die. It's impossible to make exact decisions until you almost open the patient sometimes, let alone CAT scan and ultrasound in experienced hands. And just, I think a lot of this is really preparing the medics so that they don't get PTSD from this stuff, that they know they did a good job, and there's no
Mm-hmm.
such thing as a perfect job. And if we're not sticking you in hospitals 1 or 2 months a year to think that you're going to magically go through a dozen or a couple of dozen patients and pick out the worst ones is fantasy. We're doing the medics a disservice,
Yeah,
let
absolutely.
alone the patients. That's a separate
Absolutely.
discussion.
Oh yeah. 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 Cool. To be honest, I think I'm good at the moment. Um, as depressing as this is. Stacy, do you have anything to leave us off with?
Keep it simple. That's all I can say.
Yep. Duck Rush.
Keep it simple. Internalize some of these basic principles. You will do a good job and feel good about what you're doing. So if you're prepared, you've rehearsed, and you stick to the basic principles and then deviate as needed, you will be an awesome medic.
Sounds perfect to me. All right. Thank you very much, both of you.
Woo-hoo. Right on.
Dennis, I hope we didn't freak you out.
That's it for today's podcast. Be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy, it's waiting there for you.